All right, it looks like it's 10 o'clock and we'll begin. I'm going to turn the presentation over to Stephanie Clark. She is one of our educational specialists here at St. Elizabeth, and she's put a lot of effort into looks like it's going to be a good program. So thank you, Stephanie, and I will turn it over to you.
Thanks, Tony. Let me go ahead. I'm going to share my screen so I can get my PowerPoint up. Come back. Back here. Oh, really? Come on. Okay, so what are you guys seeing right now?
I see your PowerPoint and your notes. So,
Okay.
Josh, you're probably listed as a attendee. Do you see the same?
Yep.
Yeah. Okay. That's fine. Well, see if I can share it a different way here.
There it is.
Okay. Good deal. Minimize that. Okay, so we will get started. So as Tony said, my name is Stephanie. I am the clinical educator for the neonatal ICU at St. Elizabeth Edgewood. I've been a nurse in the maternity field for 25 years, spent most of my career in labor and delivery, and then the other portion here at the NICU in St. E. I'm here to talk about the best way to support babies that are born outside the hospital with what you have available. So the objectives we're going to cover today, just taking a quick overview of the transition from intrauterine to extrauterine environment, and then what you want to know in the field to how to best support these babies. So it is all about the lungs. If you remember nothing else from this education, you want to remember that babies are respiratory driven. This is very hard for ED and EMS staff because you are so adult driven that you think cardiac. But these guys are respiratory driven, so it's very important that you support them from a respiratory standpoint versus a cardiac. 9 times out of 10, if you can get them breathing again, everything else will fix itself. So like I said, that's going to be the number one thing to try and remember. So newborn transition, when babies are in the womb, they practice breathing while they're surrounded by their amniotic fluid. As they take their first breath after the delivery, their air starts to push the fluid out of the lungs in preparation for being outside the uterus. In this visual, you can see how that transition occurs, and you can start to think about what might happen if that transition doesn't occur or if it doesn't occur correctly. If the fluid is still in there or it's not completely out, they tend to have some respiratory issues. And so we'll go over different ways that you might be able to support that. The initial evaluation you want to do within the first 30 seconds if you're there for the delivery, or even if you're not, just to get an idea of what you're working with. So you want to ask the questions or be thinking about, does the baby appear to be term? Is the baby crying? Does the baby have good tone? Some different ways that you can kind of tell is by how shiny their skin is, how translucent they are, their size. You can also tell by how flexed their arms and legs are. The more flexed they are, the more likely they are closer to term. These are some pictures over here on the left-hand side of The bottom one, that's the tiny one, I believe it's like a 26, 28 weeker. They can be much shinier than that. The top one is kind of what we call a late pretermer, so around 33, 34 weeks. And then the top one is a term baby that you most likely would see out in the field on your calls. So again, the initial steps, you want to warm them, dry them, stimulate them. This all helps with the transition from being inside to outside. You want to make sure that you've got them in a sniffing position and that their airway is clear if they need to have that done. If they're screaming and crying on their own, their color's getting nice and pink, you don't have to worry about suctioning them. But if you are seeing large amounts of fluid coming out, or they seem like they're having some issues, then you'd want to go ahead and suction. And we'll go over that here in a minute. If they appear to be on the very small side, place them in plastic wrap with a hat and warm blankets. And if possible, try and keep them skin to skin with mom, even if they're in the plastic wrap, because her body temperature will help to keep that baby from losing its heat. So, born outside the hospital. The following slides are actually recommendations from the 9th edition NRP, which just came out for outside of hospital deliveries. And so, we're going to take a look at that. And then the second half of this presentation, we're going to talk about how to handle small babies. So the main things to remember: temperature management, ventilation, heart rate, oxygen management, an alternate airway, chest compressions, vascular access, and medications. Really, your ventilation and temperature management can be interchangeable. I would say ventilation is number one, temperature is number two, and then, going from there. So temperature stability, if respiratory support is the number one way to help a baby, temperature stability is number two. If that baby is unintentionally has become hypothermic, they will burn through all their respiratory reserves and all their glucose stores to help maintain that temperature. And then you're going to be trying to take care of and resuscitate a baby that's already behind the 8 ball. Try and keep the space that they're in around 75 degrees. That's really important. They will lose heat really fast. Warm, dry blankets, put a hat in place. If and when possible, I know that there's regulations around trying to transport mom and baby together, but if you're able to keep them together, have mom do skin to skin, keeping several dry blankets over both of them. Her body heat, like I said, will help to regulate the baby's temperature. And then for very small babies, having some type of plastic wrap or polyethylene wrap will help maintain that temperature as well. Along with what's called a thermal mattress. And it's exactly as it sounds like. There's a chemical solution within the pack that you break or activate that heats up that fluid and is good for, I believe it's about an hour before it starts to lose its heat. I've had a couple of different conversations with some of our community people, Chris being one of them, about trying to find a way to get some of these things on your rigs for you. So, we'll continue those talks and see, if there's a way that we can create what we call preemie packs in the NICU, where it's a gallon size storage bag that would have all the immediate things that you might need. So hopefully we'll be able to find something if we start seeing smaller babies delivered out in the community. On the picture, this is what we call a NeoHelp. This is what I was referring to when I said finding some type of polyethylene bag. It looks like a little rain poncho that you just put the baby in the bag, it Velcros up, you can put the hood on and cinch that up, and then put blankets over them to help keep them warm. This is what we use in our NICU. So again, like I can't stress enough, ventilation is the single most important step. So once you have dried and stimulated and suctioned if you needed to, there's an acronym that NRP uses called Mr. SOPA to help you try and troubleshoot some things. So M stands for readjusting the mask, making sure that you have it done, that you have it correctly, you've got a good seal, that there's nothing wrong with it. Repositioning your airway, making sure you're in that good sniff position, that we're not overextended or underextended. Suctioning, so that's suctioning their mouth first, then their nose, to make sure that all those secretions are out of the way. The O stands for open mouth. You want to be able to get as much air into that baby as possible. P is for pressure, which is not something that you guys will be able to control, I don't believe, on your rigs. This is more for in hospital. The respiratory devices we have the capability of increasing the positive pressure that we're using when we're ventilating. And then if you've done all those things and the baby still isn't responding, then you want to look at an alternate airway. These are just a couple of positions for that sniffing position to make sure that you have it the way that you want it. If you needed to, you could take like a small towel, washcloth, or anything that you might have in the rigs and roll them up and put them under the shoulder. That helps to really open their shoulders up and open that airway. All right, so signs of ineffective transition. When they are struggling, some of the things that you might notice are irregular breathing patterns, or they're not breathing at all. They might be breathing too fast, which is typically somewhere around 70 or 80. They might have a really low heart rate or a high heart rate. If they've got a heart rate above 200, something's going on. You might notice a decrease in their muscle tone, or if you have a pulse ox on, you might notice that their oxygen saturations aren't matching how old they are. So those are some things to look at. You might notice that they're having some retractions, really struggling to breathe. Those are the times that you want to offer respiratory support. So for ventilation, babies that are apneic, which means they're not breathing, or if they're gasping or heart rate less than 100, you want to go ahead and start ventilating for them or breathing for them. You're looking to do 30 to 60 breaths per minute. So to me, I think of a waltz for anybody that might know country music. So the rhythm is breathe, 2, 3, breathe, 2, 3. So you're going to say your breathe as you squeeze the bag, and then as you're releasing, you're going to say 2, 3. And that's the rhythm that you're looking for to help give them that support. Normal respirations are anywhere from 30 to 60, which is why we use that as our parameters. So for oxygen management, the chart that you see is a pre-ductal oxygen saturation chart. This tells us, based off of how old they are, where an acceptable range for their oxygen levels to be. If you do need to use a respiratory device, you're going to want to make sure you're putting a pulse ox on so that you can manage them as best you can. And you want to make sure you're putting it on the right wrist, because we want to know the amount of oxygen that's going into the heart to be able to support them. One thing with newborns or with neonates, when they are first born, the blood goes to all the important things first, then out to their hands and feet. So it is very common for their hands and feet to look a bluish purple color and to not have a good reading on your oxygen up to a couple of minutes until their body can kind of regulate itself. So you want to be patient. You want to give it a couple of minutes and then, adjust your oxygen as you need to. Does anybody have any questions so far? I don't want to speed through this and not be able to answer questions. Okay. Um, so heart rates, NRP, if a heart rate is below 100, you're going to start ventilation with that bag and mask. If you are ventilating correctly, you should see an increase in that heart rate quickly within seconds. You want to make sure that you're listening with a stethoscope. You can use the pulse ox reading. You can even use a Doppler if nothing else seems to be working, or you don't, for some reason, something happened with the stethoscope or whatever. You can also use a Doppler if you have that with you. If they are small enough, because they are so translucent, you might be able to visually see their heartbeat and be able to determine if we're beating too slow, too fast, what's going on. So just kind of another visual that you can use. So your alternate airway, if you've followed that Mr. SOPA acronym to troubleshoot and you're still not getting a response, NRP actually recommends placing an LMA in the field instead of actually trying to intubate. Intubation, especially on a neonate, depending on how young they are or what's going on with them structurally, takes a lot of skill and a lot of experience. And if you're in a stressful environment where you're not used to doing that, you could potentially cause damage before you could ever get them intubated. So an LMA is a really simple way to get an airway that works without having to worry about seeing vocal cords or making sure you're in correctly. So once that LMA is in, you want to provide about 30 seconds of ventilation before you're jumping to chest compressions. Everybody, including NICU providers and NICU nurses, if that heart rate is, less than 60 or they're not breathing, they want to immediately jump to chest compressions. We really need to make sure that they have that adequate airway first. Like I said, because they're so respiratory driven, doing compressions on them is not going to help them. It's really getting them to ventilate that will be important. One thing to note, though, that I have on this slide is to verify that your state licensing board or your regulatory agency does that have that as a part of your scope of practice. I would assume for you guys it would. Not all state regulating agencies will allow nurses or respiratory therapists to do that. So just to make sure. All right, chest compressions. The slide is a little busy, I apologize. But if you have a heart rate that is less than 60 after you've got adequate airway, then you want to go ahead and start those chest compressions. And obviously you want to coordinate them with your ventilation. You're doing a 3-to-1. So you're going to do, your 1 and 2 and 3 breathe. The person doing the chest compressions is usually the one that's calling out the numbers so that the person that's manning the respiratory equipment will know when to breathe for you. So as you release the chest, make sure you're saying and then when you're compressing, you're calling out your number. It's a pretty fast ratio. Like I said, it's 1 and 2 and 3 breathe, 1 and 2 and 3 breathe. We do also recommend that you put your hands, like your palms underneath the baby, and use your thumbs for compression, just like they do in CPR, to have that support that you may not have if they are on a softer surface. Vascular access on these guys can be very difficult. Ideally, a umbilical venous catheter would be the preferred method. But again, that goes back to whether or not that's something that you are practiced on in the field or have ever been trained on, seen. So you could try for an IO. I know that can be a go-to. Babies have to be over 3 kilograms in order to use an IO. They should not be used on your very small or very premature babies. PIV access is your last resort, only because babies are typically constricted and can be difficult to place. Even in the NICU, sometimes it takes us 5 to 7 tries just to get an IV on a baby that is not as compromised as what you might see. So IV access for you guys may be a challenge.
Hey, Stephanie,
Yeah.
do you have any thoughts on uh, IV access in the scalp?
If you can, I personally love scalp veins. I think they're stable. They're not as hard to, they're easier to manage. The babies aren't going to be able to pull them out as much. So if you think you can get a scalp IV, go for it. Um, Again, the little ones, the smaller they are, the harder it is for everything. But I don't think, based off of what I know and what we have seen come through Edgewood, you aren't delivering babies that are that tiny. So you probably would have some relative success putting in scalp IVs.
This may be simple, and can you kind of review the technique? Because it's different than, an arm or a leg.
It is and it is and it isn't. So if you're going for the scalp, the one thing you want to do, just like you do for well, I don't know, out in the field, it might not be as big of a deal on adults, but you want to make sure that you're not putting it in an artery. So obviously check for a pulse, because you do have some arteries that run through your through the scalp that live right next to your vein. So make sure that you don't feel a pulse. Um, what we tend to use from a tourniquet standpoint is a small rubber band that will take like a 2x2 to just be able to pull it off quickly, so that you can see that vein a little better. Make sure that you are going, let me think about this, that you're going towards the heart. So if you're looking at the baby, you want to have your needle going towards the back of their head, so that everything is going down towards their heart. Um, Having the skin fairly taut can help to stabilize the vein, although their scalps are pretty tight to begin with. With whether for newborns, whether it is a scalp or a on the hand or the arm, you want to go more shallow than you think. Um, you will not go at the typical angle like you do on an adult. I think it's around like 20 degrees. It's pretty shallow because their veins are going to sit right there on the edge. But it's similar to an arm and a hand. You just want to make sure that you're going in the right direction. And then when you go to tape, you'll tape the same way. If they have a lot of hair, just try and move the hair out as best you can. But unfortunately, you can't really shave a baby's head in an emergency. Um, those would probably be my big ones, is making sure you're not going in too deep, making sure that it's not an artery, and you should be fine.
Perfect,
Any
thanks.
other, yep, any other questions? Okay. So medications for neonates during an immediate resuscitation, there are only two medications that you need to remember. Epinephrine and saline really are the only two things that you need to remember. So epi is being used if a heart rate stays below 60 after you've done all the things. You've gotten the ventilation, you've done chest compressions, and you need to move on to your next step. Then you would go ahead and try a dose of epi. One thing to note is if by now If your oxygen is not at 100%, go ahead and put it to 100% if you have that capability. I'm not sure how the ambulances are set up to regulate that sort of thing, but I guess get it as high as you can. This is the summary page from NRP. So we've got the concentration of the 0.1 milligram per ml. You can give it either through the ET tube, you can give it through the IV. You want to make sure that you are drawing up the largest dose for that route so that you can whoever's giving the medication to determine, do they want to give the whole thing? Do they want to give half? What do they want to give? But we always draw up the whole amount, and typically they're giving the whole amount. Epi, as I'm sure you guys know, you can repeat it every 3 to 5 minutes if the heart rate remains below 60. If you are changing routes, so you gave a dose of ET epi, you get an IV access, you can go ahead and give another dose of that epi right away if you want to. You do not have to wait the 3 to 5 minutes if you're changing the route. If you're using the same route, then you do have to wait that 3 to 5 minutes. You are going to push it fast. And then again, with NRP, regardless of their size, they recommend flushing with 3 mLs of normal saline to get that circulating through the system if you're doing an IV dose. Any questions about that? Okay. And then the normal saline is just used as a volume expander. Saline is very easy to remember. It's basically 1 10 ml syringe for 1 kilo of size of a baby. So you'll have to use some judgment there, but you don't have to worry about calculating like you would with the epi. It's very simple. If you have, if you think you've got a baby that's around 1,000 grams, give it a full syringe of normal saline. Things that you would want to think about if you are getting ready to give normal saline is if they haven't responded to any of the measures, then you want to think about, are they, in some type of shock? Do they have some acute blood loss? Things that you would want to know about mom, if she delivered before you got there, is, did she have some heavy bleeding? Do you think that she abrupted? Things to that effect would be why we would want to use the volume expander. You want to make sure that you push it slowly though, because it can increase cranial pressure, which if they're small enough can potentially cause a head bleed, which obviously we don't want to do. So you push it fairly slow over about 5 to 10 minutes. Okay, so the second half. Some nice to knows about stabilizing a neonate. So these next slides were actually taken from another national program out there called STABLE, which actually stands for sugar and safety, temperature, airway, blood pressure, labs, and then emotional support if they're within the hospital. So the 3 pieces that I pulled from to talk about are airway, temperature, and then sugar and safety of the baby. Out in the field, I think these are the 3 that you want to know the most. Again, I've emphasized the airway and the temperature, and then sugar's another one for babies. If their sugar gets low, then you run into temperature and respiratory issues. They all like to go together. So for airway, we'll take a look at assessing for respiratory distress or respiratory failure. We'll quickly discuss some different type of respiratory diseases, some airway challenges, and then different methods to support the airway. For temperature, we'll look at loss of body heat, how to reduce that heat loss, what hypothermia in preterm infants means and can do, what the consequences are, and then how to properly rewarm or keep a baby warm. And then for sugar, we are going to look at what causes them, what makes them at increased risk for having low blood sugars, IV placements, which we've talked about a little bit already, and then how to treat that if you are not at the hospital yet. And mind you, if you're if you're delivering to Edgewood, which I'm assuming you would, if you're picking up from either an outside hospital or if you have the number to the NICU, you can call the NEO that is on call, and they can help guide you as well. That's kind of the standard for the outside EDs, is that they should be calling the neonatologist that's on service at Edgewood so that they can get an idea of what's happening and help guide them. So remember, you have that resource as well. If you ever get caught in a situation and things just don't seem to be working correctly. So again, neonates are respiratory driven. There are two different types of ways you can support them depending on how they're breathing. You can either do CPAP, which is just holding the mask over their face and giving them some little extra pressure in their lungs after their exhale. Or if you need to ventilate for them, you can actually ventilate for them. But making sure that they've got that good respiratory support. Again, if you are, if you need to ventilate, make sure that you have that adequate airway, and you're following that, Mr. SOPA. So a couple of things, making sure that you're looking for good chest rise, you're listening for your breath sounds, and then having that pulse ox on your right wrist will give you indications as to how your baby's doing. So for the airway, like we've said, normal respiratory rates are 30 to 60. If they're breathing normally, they don't have any nasal flaring, they're not grunting, they're not retracting, their color's looking good overall. Their hands and feet might be discolored, but they're central, their gums, their lips, their chest, all of that is nice and pink. When you're listening, their lungs sound nice and clear, you're hearing things evenly. It is not uncommon for these babies within the first couple of hours or so to be tachypnic, which is a respiratory rate greater than 60. If that starts to climb, and like I said, 70 to 80, you're probably going to see a shift in their respiratory status. Then you might want to provide some respiratory support. If they're breathing less than 30, then you're probably going to need to provide some type of respiratory support because it's most likely associated with labored breathing. And this could be the start of an impending respiratory failure. So if babies aren't receiving oxygen, it can be from neurological injury, it could be a metabolic disorder, certain medications that maybe were on board before delivery, a neuromuscular disease that they weren't aware of, or severe shock. If they are severely depressed or extremely sick, they may develop gasping, at which point you want to be ventilating for them because they're not going to be able to do that for themselves. And then take a look at the shape and size of their chest. Is it round? Is it symmetrical? Are we looking barrel shaped? If you are familiar with checking for pneumos, take that translucent light and see if you can't see if there's a potential pneumo going on that might be causing some air trapping. But those are some common things that you might see as to why they aren't transitioning well. So I might jump through some of these a little quicker just because I want to make sure we've got time for some questions. Again, comparing and contrasting to each side of the chest, making sure that they're sounding even. If you're hearing crackles, that's usually present right after delivery because the fluid is still trying to get out of their lungs. If you're hearing rhonchi, that's probably due to some kind of obstruction from either mucus or secretions, or a decrease in airway entry. So it could be from meconium. Maybe their fluid was stained meconium, and that could be causing some issues. We talked about the work of breathing. So if you hear a grunting, they sound like, it kind of sounds like they're bearing down a little bit. They're trying to attempt to increase their lung volume to help open up their alveoli. They will, what they do is they partially close their vocal cords, which traps air in there when they exhale to give them that pressure. It can be common with when they first are born, tends to start about 30 minutes after the birth, and then it should stop within 2 to 4 hours. It should be decreasing, not increasing. If you notice that it's getting worse, they're having other signs of respiratory distress, again, either provide them some CPAP or some ventilation if you need to. So retractions, you will see, they look just like adults. You'll just probably be able to see them a little better. If when they breathe in, you'll probably see the skin within their ribs suck in or underneath their rib cage suck in. If it's mild, it'll just be like a slight indentation. If it's severe enough, it's going to look like they're trying to suck their rib cage to their backbone. Again, those are all signs that this baby is starting to wear out and will need some assistance from a respiratory standpoint. Skip that. One thing to remember is neonates can change on a dime. They might be just fine or be having some mild respiratory issues, and it can turn to moderate or severe very quickly, like within minutes. So making sure that you're keeping a constant eye on them, noticing any kind of change will help them out. So ways to help handle their respiratory status, again, keeping them very warm, placing them upright, spot checking a pulse or keeping them on a continuous pulse ox, and then if you have the capability, checking a blood glucose level. Okay, I will send these slides to Tony so he can send them out to you. But like I said, some of this I think will not pertain now that I'm looking at some of it. And like I said, I don't want to run out of time. All right, temperature. Normal temperature for babies is anywhere from 97.7 to 99.5. So again, trying to keep them in a normal temperature range will help to minimize their metabolic use, their sugars, their respiratory, all of those things. So it's very important to keep them warm and dry. Anything below 97.7 is considered hypothermic. So depending on how low their temperature is determines how hypothermic they are. And this can contribute to morbidity, to mortality, especially the younger they are. So again, very important to make sure that we are supporting them from a respiratory standpoint and supporting them from a temperature standpoint. Making sure that you're removing the blankets as you're drying. If you are drying them, swaddling them in warm blankets, skin to skin, putting a hat on. If mom has clothes, throw them in clothes. Um, if you're having to do a prolonged resuscitation, there is an increased risk that they're going to get cold. So just try and keep that in mind as you're running through that. Keeping them off things that are wet or even damp will help a lot. Infants that are at risk, your preterm babies, or your very low birth weight babies, if they're tiny, infants that need prolonged resuscitation, if they're acutely ill, um, any type of open wall defect, or a decrease in their activity, or if they're hypertonic. So what happens when they get cold stressed? They use their brown fat, they metabolize it to help with to increase their temperatures. The younger they are, the less brown fat they have. Um, so that can play a huge factor. Um, they they do not shiver. They don't have that capability. So they use something that's called non-shivering thermogenesis. And this requires oxygen and glucose. So as you can see, everything ties together. Let's see. You'll see an increase in muscle activity or inflection. They don't have the capability to shiver. They might increase their crying. Um, Let's see. So some things that you can do to reduce that heat is making sure that whatever they're laying on is not freezing cold, because that will pull their warmth from them. Try and keep them away from drafts if you can. Um, Keeping them, like I said, wrapped up. Let's see. So this is kind of a nice visual over the different types of heat loss. And so you can see, so for conduction, if you put them on something cold, that's pulling all of the heat away from them. The convection, that's that draft. Evaporation. So if they're getting too hot, they can do what we call sweat down, to where they will lose heat to try and drop their body temperature, but then they can go too far. And then you've got the radiation. So if they're near something like a cold window or anything like that, then it will pull the heat from them. If they are not protected from the heat loss, infants will drop their temperatures as quickly as 0.2 to 1 degree per minute. So they can drop very rapidly. Um, so again, preventing heat loss can very much help with any of the other effects. Glucose. So glucose is the body's number one fuel source. And so for babies, it is very important, because they depend on that to do all of their bodily functions, their brain, their growth, all of those things. When they're inside, they are getting it from the placenta. Once they are born, then their body has to produce it on its own and do its own breakdown, and that can take some time. Um, we've got babies that sometimes it can take up to a week in order for everything to work the way it's supposed to. So glucose is stored in their liver, heart, lungs, and in their muscle. Um, it increases slowly during the first and second trimester, but most of it is stored during the last half of their third trimester, which is why the smaller they are, the more likely they are to have blood sugar issues, and are harder to control. Uh, so things that will put a baby at risk. Like we said, preterm infants, the younger they are, the more likely they are. Small for gestational age or large for gestational age. If you know that mom is a diabetic, when you go to get her, or she tells you that en route and you're getting ready to deliver, that's very important because we want to get the baby fed as soon as we can. If they're stressed or sick, and then if they're exposed to certain medications, it can cause their glucoses to drop. Um, that won't apply to you guys. So some neurological things that you might see, um, tremors or jitteriness. The tremors almost look like they might be having a seizure. They're very irritable. They might be hypotonic or very lethargic. They could potentially have seizures. You're going to see a shift in their respiratory status. They're going to be breathing really fast. They might decide to not breathe at all. Um, and they might change color on you. Um, so I sped through those pretty quick. Um, Before we go into questions, I was asked to kind of do a quick talk over um, babies that are exposed to opioids while pregnant, or babies that did not have any prenatal care, and are there any special considerations for for that population? The short answer is no. Um, Now's babies, most of them tend to make it to term, and they don't start showing symptoms until about 4 hours after birth. We don't do anything special for them. We actually work to keep them with their moms unless they have to be medicated. So there's nothing from caring for the baby that you would need to worry about right after delivery. Um, I will tell you, cocaine does have the capability of causing a placental abruption and causing mom to deliver early. So if you come on a delivery or on a scene that there's, mom has excessive bleeding, she's got severe pain, she's delivered early, and either she verifies or you suspect that there's cocaine use, then you want to think about um, all the things we talked about at the start, the epi, the volume expanders, making sure to share that information with the team when you get to the hospital. That's probably really the number one. But we don't see that too much around here. I will say, knock on wood. Most of our babies that we are seeing that were exposed to substance use disorders are actually moms are in programs and are on prescribed medications. We don't see too many that are doing a bunch of street drugs. The no prenatal care, that's a hard one because you just don't know what you might be getting. I feel like we've been lucky in that we haven't seen a lot of anomalies that you can't handle during delivery. Um, we haven't seen any wild abnormalities, disorders, or anything like that. But a no prenatal care, if you hear that, just know that you might get anything. Um, Statistically, we don't see a lot of preterm babies, at least with our substance use. In 2025, we had 31 that were born prematurely. And then in 26, we've got 15 that were born prematurely so far. And that premature is like 33, 34 weeks, not like your very tiny, 22, 23, 24 weekers. So, or even your 26, 28 weekers. So with that being said, what questions does everybody have? I know that was a lot of information.
So Stephanie, I do record these for everybody so they can go back and look at it, share it with their other shifts,
Okay,
other
perfect.
crews. Um, Sometimes they reach back out a day or two later
Yeah.
to come up with questions or whatever. But having the latest information on from NPR is really important. Our regional protocols are in the process of being reviewed uh, right now, and they'll be released soon. And a lot of the information you shared is included in that
Oh, good.
through um, Children's Hospital has a big say in our pediatric uh,
Yeah,
protocols,
yeah,
and so kind of giving them a heads up on what's coming in changes in our protocols, which is great. Um, yeah, our umbilical cord cannulation protocol has been in the protocols, out of the protocols, in the protocols, out of the protocols.
yeah. That's what I've heard.
Uh, it's a it's sad because it's a skill that can be really important, especially you have a prenatal delivery
Yep.
and they're not right for an IO. And like you said, an IV, even, with a skilled practitioner is difficult. So that umbilical cord is just a perfect target. And
Yeah. And and I it might be worth asking children's opinion, but um it I don't I would assume the expectation is not that you are getting it all the way into the proper place, because that requires an x-ray, all those types of things. I think even if you could get it in and get it low lying, then you could still do what you needed to. The medications that you would give are still acceptable on what we call a low lying. So basically, it would be treated like a peripheral IV. And then once they came to us, or if they had to go to children's, then that line would be removed and we would put one in under a sterile environment where we could verify that it was in complete, place, get them set up on what they needed. But, you know, I think even if you could get it, to a point where you could use it as a regular IV would help significantly.
I agree. I agree.
Has anybody
Uh,
on the call ever had to try and do, like, had a small baby that they had IV access issues? I'm just curious. What do you guys do?
I know I personally have. I had a 26-week uh, delivery that was complicated, and we did not have umbilical cord cannulation within our protocols then. We actually had the Jamshini needles at the time, and you can imagine that wasn't practical.
Yeah, no, no.
So
Yeah, it's hard.
mm. the some of the OB kits uh, come with a hat, some don't. Some of them I've seen they added that basically the tin foil. Uh,
Hmm.
what's your? I've always heard that the plastic is so much better than the tin foil because it doesn't allow the transfer of heat from mom to the baby.
Um, yeah, so the purpose of the yeah, so like I guess I've not heard about like the use of the tinfoil wraps. Um, the plastic wrap is nice because basically all of the amniotic fluid is what's helping to maintain the temperature. So if you can keep that contained with the baby, then that works better. I could see where, if you're trying to keep the baby skin to skin with mom, then yeah, the saran wrap would work much better because you can wrap both mom and baby in it with those tinfoil like reflective blankets or whatever they are. I've used those before for me, and I don't think they did a whole lot of good. So I can't imagine on a baby that's got no fat that would be real beneficial.
Right. It's not producing its own heat really,
Yeah.
uh,
Yeah.
to reflect it back.
Right. So that's where, we I think we've tried to get away from this a little bit, but we used to joke, the plastic wrap, or like even if you just had like a Ziploc bag, we put it in there, we put the baby in there to keep cooking like you do a turkey. That's what we used to say. To help the juices cook the turkey. So it's the same concept with the baby, is that fluid around the baby will help to maintain that body temperature. So any type of plastic wrap would work, or like I said, plastic bag. Um, the OB kits that you guys have, where are you guys getting those from? Are you purchasing those from someone?
Yeah, they come from a
A vendor.
Boundary, Par,
Okay.
whatever. Yeah.
Okay. Yeah, it'd be nice if they had something that was a little more conducive to the smaller population. But my guess is that you guys tend to see bigger kids and you don't see those small kids as much.
Yeah. Yeah. So, all right. Well, if anybody does have any questions, they can reach out to me, and I can get with Stephanie directly or make the connection if needed. But we've set up for an hour and we've hit that mark, so I will um, put this up on the recording platform, and it'll be available to anybody who wants to watch it. Thank you again, Stephanie. I really appreciate your time and your expertise.
No problem. Thank you.
All
Thank
right.
you, Stephanie.
Thank you.
Have a good day.
All right. Thank you. Bye.